Good morning and welcome to the Insight APSAD webinar series. I would like to begin this morning by acknowledging the traditional owners and custodians on the land of which this event takes place. I'm coming to you today from Meanjin on the lands of the Turrbal and Niagara people. I would also like to extend that acknowledgement to any Aboriginal and Torres Strait Islanders who are joining us today from across the web. My name's Sam Clark and I'm one of the nurse educators here at Insight, and I have the pleasure of facilitating today's webinar, Prenatal Exposure and Fetal Alcohol Spectrum Disorder, and our presenter today is Dr. Natasha Reid. Dr. Natasha Reid is a Senior Research Fellow at the Child Health Research Centre, Faculty of Medicine, University of Queensland. Her research specialises in the potential impacts of prenatal alcohol exposure and the whole body condition of fetal alcohol spectrum disorder. Dr. Natasha Reid is a Senior Research Fellow, and the presentation today will be looking at fetal alcohol spectrum disorder and the potential impacts of prenatal exposure and how this can be addressed by increasing access to reproductive healthcare and reducing alcohol use. The presentation will explore how to identify FASD, the impact on functioning, and tips for adapting treatment and increasing service accessibility. So without further ado, I will hand you over to Dr. Reid.
Thanks, Sam. And hi, everyone. I'm just going to apologise in advance that I'm getting over a fun time of having COVID at the moment. So I may not be firing on all cylinders this morning. But thanks heaps to Insight for the opportunity to speak to you all today and for everyone coming along. So we'll crack right in. I have a bad habit of trying to cram too much into my presentations, so I'll do my best to get through this. But you'll have the slides as a reference point, I figured anyway. So whatever we don't cover, we can always come back and do a follow-up. Gone the wrong way already. Okay, so Insight provided me with some really helpful information that I am told has come from you. So these are requests that people put in about topics that they wanted to cover around FASD. So I've tried my best to cover as much of this as we can today, but yeah, as I said, I'm happy to come back and speak more, particularly around the treatment side of things. Like, that could really be a whole topic on its own. So I'll go into that a little bit in the context of the different domains of functioning. But yeah, that could really be a whole presentation in itself. So as Sam said, we're going to talk about how we identify FASD. We're going to talk about all the different domains of functioning that are impacted by FASD or can be impacted by FASD. There was a question from someone about diagnosis in regional and remote areas, and then about how as practitioners we can change the way we're delivering treatment to make it more accessible for people with FASD. So I like to have these first couple of slides in my presentations just to give everyone a little bit of context, and also apologies, I'm at home, so there'll probably be lots of random home noises, birds and whatnot. Yeah, I'd just like to have these slides in here to make sure we're all on the same page around context about prenatal alcohol use and FASD. So we know that a lot of pregnancies are unplanned in Australia, and we know that we live in a country that's accepting of heavy drinking. So a lot of people going about their normal daily lives are consuming alcohol. And then we also, of course, this group knows better than anyone that if you've got a problem with alcohol, as you can see here, 1 in 4 people who continue to drink after becoming aware of their pregnancy, for some people stopping drinking is not a simple thing. So I think this is a really important context to set. And when we're talking about FASD, we're talking about something that is a societal problem. This is not about blaming and shaming women or blaming and shaming families. It's about raising awareness of this issue and making sure we're doing it in a way that is sensitive and supportive and can help people come forward and get the help that they and their families need. So that's why I have this slide in here to really help, I guess, with addressing some of these things around stigma. As I said on the previous slide, just up in that top corner there, I don't know if my camera thing, I'll move that down. live in a society that is accepting of heavy drinking. You know, that is all of us in Australia. We live in a country that's accepting of heavy drinking. Many of us come from families of origin that are heavy drinkers. We know that if someone has a partner who's a heavy drinker and is drinking while their partner is pregnant, that person who's pregnant is much more likely to continue drinking. We know that there's a whole range of socioeconomic factors that influence drinking and influence, you know, how challenging it can be to stop drinking. So all these things are so important for us to take into consideration, and that it's a really challenging area. And obviously, if it was a simple solution, you know, we would already have discovered that and stopped it. And it's interesting, like the people who first discovered FAST, they said, oh, this was in, you know, when they first described it as a condition in the 70s, these guys in America, you know, they said, oh, we just thought we'd tell everyone about it, you know, what it is. And then in a few years, it would be stopped. That would be it. So obviously, as we all know here in the area that you're working in as AOD workers, behavior change is a complex thing, right? Just because we know something isn't good for us doesn't mean we necessarily won't, well, you know, we'll stop doing that. So the first couple of topics that we're going to cover is how we identify FASD and what are all these areas that can be impacted for people who have FASD. So in Australia, we have a guideline, we have a guide for how to diagnose FASD. So if anyone has not seen this guide, it is freely accessible on this website here called the FASD Hub. You can go on there, you can look through the guide, you can download it. There's free e-learning modules on the Hub that you can do as practitioners that'll help you learn how to identify FASD, understand the guide, understand all the information in it. So anyone who's interested, I'd really encourage you to go on there, do those e-learning modules and just check out the resources on the diagnosis, but also just if this is an area of interest for you on the FASD Hub as well. So for when you have a look in the guide, what you'll see that we have in there is that you can get a diagnosis of fetal alcohol spectrum disorder, either with 3 facial features or with less than 3 facial features. So those are the 2 diagnostic outcomes that you can get. And how we go about coming to this decision about what diagnosis of FASD you have, you'll see here that there's 3 key areas that we look at in the assessment process. So the first one, and obviously the most important one in the context of FASD, is prenatal alcohol exposure, right? Because if there's no prenatal alcohol exposure, there's no FASD. The biggest area we spend the most time on in the assessment process is the neurodevelopmental assessment. And so you'll see there from the criteria that you have to have what's considered to be severe impairment in at least 3 domains of your functioning. And I'll go through with you in detail next about what each of these domains is. But what you'll notice is that people can present with different combinations of these 3 domains. So that's where, whilst having a diagnosis is really important and provides us with information, it's actually this neurodevelopmental assessment that helps us to understand, you know, a child or an adult, how they're functioning, and then helps us to adapt our treatment based on their individual neurodevelopmental needs. And so what I like to call that, you know, it's become, people are aware of trauma-informed treatment approaches. What I like to call this is being neurodevelopmentally informed. So what we're really trying to do here is be informed about that person's unique neurodevelopmental profile and how we need to change what we do based on their strengths and challenges in their neurodevelopmental functioning. And then you'll see there the last area that a lot of people know about, but there can be a lot of misconceptions about, is the sentinel facial features. So we'll talk a little bit about that. But at the end of the day, a very small proportion of people present with these facial features. So there's a bit of variability in the research, but we're talking about sort of 5% or even less than 5% of people who present with these facial features. So obviously, if everyone with FASD rocked up and had these facial features, that would make our job as clinicians really easy, right? We can diagnose you really easily because you have those facial features. But that is not the case. And there's still a lot of misconceptions amongst health professionals that to have a diagnosis of FASD, you have to have these facial features. And that's because previously, when people were trained, particularly in medical training, the condition that people were trained about was fetal alcohol syndrome. And so to have fetal alcohol syndrome, we don't use that terminology anymore in our Australian guide, but it is still used internationally. In America, for example, they still use the terminology of fetal alcohol syndrome, and that does require you to have all 3 facial features. So that is what we call FASD with 3 sentinel facial features. But what we see is the majority of people present with FASD with less than 3 sentinel facial features. So we'll talk through, and just to flag, we're going to talk through each of these areas, but just to flag about the prenatal alcohol exposure. So you can see here that when you've got all 3 facial features, we don't have to have a history of prenatal alcohol exposure. Because if you've excluded other potential causes of those facial features, so such as genetic conditions, some genetic conditions can present with dysmorphic facial features that could be similar to someone who has FASD. But if you've ruled that out, then we can make a diagnosis of FASD without having that history of the alcohol exposure, because the person couldn't have got those facial features any other way. But that's why it's really important to have that multidisciplinary input. So from the different people working together to gather and understand that information. So that first part, that's really important, and we can't talk about FASD if we don't have prenatal alcohol exposure. So anyone can collect this information, and I'd encourage any people who are working in all contexts, can contribute to assessment and diagnosis of FASD. So if you're seeing a client, you're just taking a history as you do for all your clients. It's good to understand if there's been prenatal alcohol exposure for anyone that we're seeing in a therapeutic context. So we can take that just as part of our routine history taking to understand someone's history and what's happened for them, or in situations where we may not have access to that information directly, we can gather that information from, say, child protection records or other legal or medical records that may be available for an individual. And so you can see from the information here that that can either be directly gathered from, say, the biological mother or other, what we would say is other reliable reporters who were there during the pregnancy. We've got to be very careful about that second point, about the direct observations, that there would be no other reason that someone would be reporting that information. And then, as I said, you could get that information from other records as well. Again, that information's got to be checked really carefully to make sure it's accurate, because we've come across situations where, stuff has been reported in child protection records that's really hearsay, and we need to dig deeper and really make sure that the information that we're getting is accurate and reliable as possible. So as you guys would know, when you're doing collecting information in drug and alcohol context, it's great where we can to use a tool to assess the level of the alcohol exposure. So what's really important in the context of pregnancy is that we get this information about before someone knows they're pregnant and then after they know they're pregnant, because we know that this can change significantly. So if you don't know you're pregnant, you can potentially just be going about your normal business and drink, which can include, drinking at very high levels of alcohol exposure. So if you ask someone, did you drink while you're pregnant? They might say no, right? Because they're counting pregnancy to be once they found out they were pregnant. So it's really important to split that up into pre-recognition of the pregnancy. So asking someone, when did you find out you were pregnant? How many weeks pregnant were you when you found out? And what sort of lifestyle changes did you make once you found out you were pregnant? So they might immediately say to you, oh, once I found out I was pregnant, I stopped smoking, or I started taking prenatal vitamins, or I cut back on my drinking, that sort of question can immediately bring that information out. If it doesn't, then you can drill down and ask those more specific questions about, were you drinking, were you smoking, were you taking any other sort of, illicit substances or prescribed medications. We want to get all that sort of information to understand what may have influenced the development of the embryo and the fetus during the pregnancy. So this is really, really important around gathering that information to look at that pre-recognition and then during the pregnancy. And depending on what context you're in, like if you're a midwife, you can be gathering this information at multiple time points during the pregnancy. And that's what this resource is from here. It's from a learning guide that's a free resource, again, on the hub, but it's targeted at midwives where they're in a position where they could gather this information, say like each trimester during the pregnancy. When we're in a context where we're gathering this information retrospectively, like say when the child is 6 or 8 or even as teenagers, we still ask these questions about pre-recognition and post-recognition. So it's still really important to break that up, but we won't ask it across every trimester. We would typically just say, before you knew you were pregnant and after you found out you're pregnant. What's really important in the information that I'm going to talk to you about next is that there's a difference between public health message around preventing prenatal alcohol exposure and when we're thinking about making a diagnosis of FASD. So the content that I'm talking to you about today and the context that I'm in is we're talking about diagnosis of FASD. So the research that we're doing is looking at understanding that, at what point should we diagnose FASD? There's a whole body of research and a whole other set of guidelines out there, which we are all familiar with, which is our alcohol guidelines, which is about public health messaging around alcohol use, and has a recommendation in there for pregnant people around saying that we should not be drinking during pregnancy or when we're breastfeeding. So that is about that public health message. So what we're looking at here, though, is at what point, at what level what level of prenatal alcohol exposure do we start thinking about, do I diagnose FASD? So currently what we're doing, we're spending heaps of time working on this. Just to give you guys a little teaser, we're currently doing a massive evidence review to help revise our guidelines around assessment and diagnosis of FASD. So this is specifically targeted at the elements that we consider for diagnosis. So I just thought I'd give you a little taster of this so you can see the types of things we're looking at and how we're doing this evidence review, because this is going to be out at the end of this year, hopefully, for everyone to have public consultation on. So we'd love to get your feedback, for you to read it, give us information about how it's written, how we can improve it. Because we want everyone, as I said earlier, we want everyone to be involved in assessment and diagnosis of FASD across all our settings, whether it's health, justice, child protection. We want everyone to get involved in this. It's the only way we're going to make a difference when we've got such a underdiagnosed and high prevalence condition. So just to give you a little taster, this is what the sort of stuff we're doing. So we've spent an enormous amount of time summarizing this evidence and making it consistent so that we can actually compare this evidence in a way that's consistent across these different levels of exposure to help answer some of these questions about, okay, well, when should we start to consider a diagnosis of FASD? And so far what we've seen across all this evidence is that, and again, this is where I'm not talking about public health. I'm not saying that, drinking at light or moderate levels is okay, because it's not, because the outcomes we're looking at are specific to diagnosis. We have not looked at all the other outcomes, hundreds of other outcomes that can potentially be influenced by prenatal alcohol exposure. But on the outcomes that we're interested in terms of diagnosis, we did not see at a light level, so up to 2 drinks a week, we wouldn't be looking at diagnosing someone. We start to get some minor effects at a moderate level, but it really is, things get really, really adverse once we hit this heavy level. So on every single outcome that we've looked at, pretty much, very few, not many, didn't see an effect of heavy or above prenatal alcohol exposure. So we're not saying, like, in terms of what the guidelines will be, that we'll have these really strict cutoffs, but just to help us as clinicians to understand when we're gathering information about risk and interpreting risk. And obviously every individual is going to be different. And so if you have someone who comes in who's drinking at a high moderate level, so at this top end of the moderate, you may consider diagnosing FASD, right? But it's gonna depend on what's going on for that individual and what's their context and what's the other factors that may have contributed to that individual's outcomes. So that's just to give you a little taste. How we're presenting all this evidence is we're trying to take a very robust and very evidence-based approach in how we're doing this. And we have done hundreds and hundreds and hundreds of meta-analyses. So all the data nerds out there, you can get your teeth into this. But basically what this figure shows you here is we've broken down this information across these different levels of alcohol exposure. So here we've got 4 meta-analyses. We've got 1 for each of those levels. So you've got 1 at light exposure, 1 at moderate, 1 at heavy, and very heavy. And as we discussed on that previous slide, what you can see here is that really clear dose response effect that's happening, where the heavier the alcohol exposure, the more effect. And the outcome that we're looking at here is about being small for gestational age, so that you're born with your weight less than the 10th percentile. But this sort of dose response pattern has been consistent across all the outcomes where we've got information across all these different levels. It's really clear dose response effect, that the more alcohol exposure you're getting, the worse outcome you're seeing on whatever the outcome is, whether it's your physical size, your facial features, or your neurodevelopment. So I won't go into all the nitty-gritty of all those numbers, but there's heaps of information that we'll be able to share with you when we put those revised guidelines out for public consultation later this year. So that's the info about prenatal alcohol exposure. Obviously, that is a really important area, and everyone can contribute to gathering that information about prenatal alcohol exposure. The next area we're going to focus on is around neurodevelopment. So this area is massive, and there's a lot of information in these slides, but I'll try, given we're on a tight time schedule today, I'm going to whip through these areas pretty quickly, but I've got references on all the slides and information about all these areas, so you can drill down into it and get more information about all these areas if you would like to. But just for the sake of time, I'll move quite quickly through each of these areas. So remember back to the criteria that when we're looking at making a diagnosis, you have to have 3 of these areas, which is considered to be severely impaired. So someone is really, really struggling in how they're going in their functioning in 3 of these areas to get a diagnosis of FASD. And that doesn't matter if you have the facial features or not, you have to have these significant neurodevelopmental impairments. So the first one that can be looked at is about your brain structure and neurology. So if you have a look in the criteria, these are the sort of things in there that they're talking about. It's about, they'll measure, so the pediatrician or the medical practitioner might be a nurse, might be a GP, whoever. And this is common, you know, nurses do this in the child health checkups. They'll measure your child's head circumference and tell you how big your child's head is compared to other children of the same age. So that's something that they'll look at and see if your child's head or an individual's head is small for their age. And that's about your overall brain size. Other things that can happen, we don't get this information a lot, but sometimes you might see people who have had an MRI and have got some evidence of some structural brain abnormalities on that MRI. This is pretty rare, We don't see that often, and it's not something that gets requested as part of the assessment process. It's not required to have an MRI to have an assessment. If it's clinically indicated, a medical professional will request an MRI, but it's not a requirement of the assessment process. In research, they can find all sorts of really interesting things, but obviously the types of brain scans that they're using for research purposes are really different to the types of brain scans that we have access to for clinical purposes. But in the research, there can be lots of different areas that they've found that can be impacted structure-wise from prenatal alcohol exposure. I've got a few of those there for you. And then other things that can show up in other neurological conditions that don't have an explanation, another explanation for it. So this is where it's all about that exclusion. So excluding other reasons for why an individual might have seizures, or why an individual might have cerebral palsy, or hearing loss, or all those sort of things, to understand if there's a known cause for those other sorts of neurological conditions. Just to give you a sense of some of those fancy brain scans that people can do. So we obviously don't have access to this sort of stuff clinically. Hopefully in the future, you know, it's something we'll be able to access, and more research will help us understand. But as you can see here in the control picture on the right, we've got heaps and heaps and heaps and heaps more connections going on for people compared to someone who's had prenatal alcohol exposure. So there's these different types of scans that can show us different types of information, but at this stage, these sorts of scans are not being used for diagnostic purposes. But there's some references there, and if that's something you want to have a look into, there's heaps of research that's been looking at this that's super interesting, and hopefully in the future will be able to be used for diagnostic purposes. Again, this is just a really interesting study that I included for you guys. It's all about how brains develop. So what they found for children who had FASD is that they had smoother brains. So, and they found that having a smoother brain is associated with having a lower IQ. So again, it's just about how that alcohol can be impacting on the development of your brain, and it can mean that you're having that cortex formation really early in your development can be impacted by the prenatal alcohol exposure. And this is a great study, again, by the same group. And I think this is a really good thing for people to be aware of, is a way we can think about FASD, as it can be described as a foundational brain injury, because the disruptions that have occurred are occurring so early in the developmental process that this goes on to affect all the other development that occurs for the brain later on. So you could think about it like when you're building your house, if you've got a cracked foundation, that's going to impact everything that you're going to put on top of that later on. So that's just a way that we can describe it to people, that what we're looking at is a foundational brain injury with FASD. So an area that there's been quite a lot of research in is our cognition, or what people would be familiar with, sort of like your general intelligence. And this is a lot of, you know, psychological assessment that people will do. So there can be reductions in this for people with FASD, but commonly it's not reduced to a level where you meet criteria for having something like an intellectual disability. And so this is, you know, ironically problematic for people, because what tends to occur is you'll have this assessment done at school, and then you won't have an intellectual disability, and then you, in the past, you didn't get access to any supports. Now this is changing with the new NCCD way that we're sort of able to qualify for funding in our schools. So Queensland is currently changing to the NCCD system. My understanding is this is the last year in Queensland of the verification system. So that's going to give us a lot more access to support for people who have FASD, because now their disability is actually going to be recognised as a disability in the education system, where prior to this, at the moment, in this last year, under the verification system, it's not recognized as a disability. You have to have an intellectual disability to be recognized as having a disability for FASD. So language is another area that can be impacted. So people, and this can be about either how well you're expressing yourself or how well you're understanding language. There's not as much literature that's been looked at in terms of language. So any speech and language pathologists out there, it's definitely an area that needs more research, but it is an area that can be impacted for people. Motor skills is another one of our domains. So this is where our occupational therapists or our physiotherapists will do some assessment and understand how your fine motor is. So how well you're able to write and draw and cut and or do all those sort of functional motor tasks as well. So we see a lot of kiddos who, will have trouble doing buttons and packages in the kitchen and using implements, like your cutlery and stuff like that. So all that stuff can be quite challenging sometimes for people, and that can really impact on how you're going at school, right? If you're really struggling with your motor skills and you don't want to be engaging in tasks in class, and same with some of these other areas as well, that can be really viewed as misbehavior, but actually someone's struggling in some of these areas. And a lot of the time they're not getting the right supports to help them to be able to access the curriculum and engage successfully at school. A really area that's had quite a bit of research is around memory impairments. And there's been quite a lot of really interesting neuroimaging studies that have been done as well, looking at changes in the brain that are associated with these memory impairments, and that the hippocampus can be quite a sensitive area to the impacts of prenatal alcohol exposure. So this could be about whether you have trouble remembering verbal information, visual information, different types of information. We might be better at recalling. So that's where that assessment really helps us to understand what type of memory difficulties someone might be having. Next one is affect regulation. I'll be frank, I do have some challenges with how this is defined in the current criteria. What it currently requires is that someone needs to have a diagnosis of a mood or an anxiety disorder to meet this criteria. There is a lot of evidence showing relationship or association between prenatal alcohol exposure and impacts on different systems in our body and brain that are associated with mood and anxiety, so that prenatal alcohol exposure can put us at increased risk of experiencing mood and anxiety difficulties. And I think that's really important. I don't think you should have to have a diagnosis of a condition to meet criteria for this. I think it should be based on your symptomology, that if you're experiencing regulation difficulties in emotions and behavior, that should be considered here. Just putting that out there. But it is a really important area, particularly as clinicians, for us to understand that people with FASD can really be struggling. And we see a lot of young people who are really struggling, particularly with anxiety, and it's gone undiagnosed. And it's put down to behavior, because they can present really angry and a lot of aggression and that sort of stuff. But when you dig down into it, there's a lot of anxiety there about their performance, about their disability, not understanding why they're different to other kids, not understanding the challenges that they're having, and all that sort of stuff can manifest in really significant anxiety, and people can often go really unsupported for that. So this is a really important area, I personally think, about understanding anxiety and mood and how that's impacting on people's behavior, rather than viewing it as a behavior problem. Executive functioning is an area that we can see a lot of challenges in for people, and this can obviously impact on a lot of the things that we do in our day-to-day functioning. So, we take for granted our abilities to plan and organize ourselves and stop ourselves from doing things that we shouldn't do. But a lot of the people that we work with FASD can really struggle with this. So, a lot of the young people that we see can get themselves into a lot of trouble with not not being able to stop themselves from doing things that they shouldn't do. And obviously this can have a lot of interaction with substance use as well. Attention is a really interesting area and can be a really common area that we see challenges for people. This paper's got a really nice summary of that and of other neurodevelopmental areas. I'm pretty sure it's even open access, so feel free to access that and have a bit of a read. But yeah, this is a common one that we see for people. Can be more often challenges with inattention than what you typically might see with like people being really hyperactive. So it may not come across as that sort of, person who can't sit still and is out of their seat. Sometimes we do see that as well. But what we can see more often is people who are more inattentive and impulsive than rather that sort of hyperactivity. But again, people are so different. Having FASD doesn't mean that you're going to present a certain way. So it's all about that assessment and seeing what's happening for individuals. But overall, we do tend to see more inattentive attention problems. So obviously, when you have these sort of challenges, it can impact on your academic abilities. And this can particularly be seen for people more often in maths challenges than other areas, but we see people who have a lot of challenges. But again, this can also relate to a whole lot of other things, right? So it's really important to understand what's going on for someone. Have they missed out on a heap of school? Is it that they haven't had exposure to learning is actually what's going on? So this can be a tricky area to look at and check out, but yeah, that can be an area that people can struggle with. And then obviously putting all this stuff into practice and going about our, in the day-to-day world, when you're struggling with all the things we've discussed, can mean that things can be really hard for you. So it can be hard for you to go about your daily jobs that we take for granted, being able to do all our chores around the house and engage with people at school, and all that stuff is really, really complicated. So this is a really common area that people will struggle with their day-to-day activities, their social skills, and their social communication. So sensory processing is not actually considered part of the criteria, but this is an area we always assess as part of our assessment, because we find that it helps people to really understand something about themselves. And parents particularly find this really helpful to understand how things can be really triggering for their child, that their child can have these meltdowns and they don't seem to have a reason. But then when they understand about sensory processing, they come to see that their child was really overwhelmed, by a particular situation or particular things that were going on for them. And so we find that this can be really helpful to helping people understand what's happening, even though it doesn't count towards the diagnosis. Again, this is our great occupational therapists who are awesome in this area. And occupational therapy is something that a lot of families report is a really helpful therapy, because it really helps with a lot of these regulation challenges that people present with. So yeah, really can encourage our occupational therapists out there to get involved in FASD work. We need more of you. So as I flagged at the start, what we're really trying to do here is have a neurodevelopmentally informed approach to our treatments. So I know we're getting tight on time, but feel free to pop in any things into the chat that as we've gone through these areas, when you're thinking about, okay, now that I know about all these different neurodevelopmental domains, what sorts of things would you be thinking about in your treatment that you'd want to be adjusting and want to be, changing the way that you might be approaching supporting a child, a young person, or an adult who has FASD or you suspect might have FASD? Feel free to pop any of those ideas that have come to mind for you in the chat, and we can see what sorts of creative suggestions people are coming up with. Because what I'd be thinking is you guys are all a bunch of really experienced and skilled practitioners out there. And this, what I find when people go through these neurodevelopmental domains is they start to think about that. Oh, So if I've got a client who's, having memory impairments, this is what I'm going to need to do. They're not going to remember what we're going to cover week to week. We're going to need to have some visual support. So we're going to need to do repetition of the information. We're going to need to slow it down. We're going to need to come back to it. All that sort of stuff is these type of accommodations that we're going to need to make the therapy successful for someone who has these sort of neurodevelopmental impairments, right? Nothing in there. No one wants to really. Yeah, there we go. Thanks, Emma. Yes, providing shorter, repeated instructions throughout therapy, visual/auditory support. Yes, exactly. So depending on if someone has a strength in understanding visual information or understanding verbal information, we can be providing more of that and repeating that. And repetition is big. Yeah, repetition is really big. So that's a great suggestion, Emma. Yes, giving lots of breaks. So if someone is struggling with their attention, they may only be able to pay attention for 5 minutes, right? That might be the max. So it may be that you have to set a timer, and it's going to be that you do 5 minutes of content, then you have a movement break, then you do another 5 minutes, and then you have a movement break. Maybe they can pay attention for 10 minutes. So, it's about really adapting those sessions so that that person is going to be able to successfully engage. Yes, consider the environment, don't overload. Yes, fidget tools are great. Having access to different sensory tools can be really helpful. So you could have your putties, you can have those little fidgets, different fidgets that are really good. So all that stuff can be really helpful. Oh, now we're coming in hot. Lots of great suggestions here. Yes, having a writing pad. So if people really like to write, or I have clients who will take notes in their phone. So it's, whatever works for them, they could write it down. They can keep their notes so that everything that you're discussing, that sticks with them. They can record that and come back to it after the session. Yes, great suggestions. Awesome. Yes, visual tools to communicate emotions. Awesome. So we want to make things really concrete. We want to help people have those really clear examples of things that you're talking about, particularly when you're dealing with really abstract concepts. So anything that you can do in your therapy to make it more concrete, make it more engaging is going to be really helpful for people to get involved with. Awesome. Make friends with OT colleagues. Yes, definitely make friends with OT colleagues. OTs are awesome. Definitely encourage that. They're really good at this stuff. Okay, you guys are killing that. So I'll quickly, given we're running short on time, I'll quickly whip through this next section for you guys. Give you a little bit of info about the facial features. So we touched on that, but for anyone who hasn't seen this, these are the facial features that I'm referring to. So there's 3 facial features. You have your palpable fissure, or which is just the distance from your eye. So you can see there that we measure from that corner to that corner, and we do that for both of your eyes. We look at the smoothness of your philtrum, so that groove above your lip, and we look at the thinness of your upper lip. So you can see this scale over here that goes from 1 to 5. We've got 1 down here, which is basically like Angelina Jolie, and then you're going up here to someone who has a very thin upper lip and a very flat philtrum. So you're looking at how wide their lip is and how flat their philtrum is. And then that gets ranked from 1 to 5. Anything that's a 4 or a 5 is what we consider to have this feature. And from 3 to 1 is considered to be within the typical range of your philtrum and your upper lip. Because obviously there's variation in that, right? Some people have more fuller lips naturally. Some people have thinner lips naturally. So it's only once you get to this level that you're considered as that feature being present. But as I discussed earlier, this is really about the iceberg, because this is the tiny number of people up here who have the facial features, but we've really got this whole massive group of people down here who have this foundational brain injury, but it is not visible to people. So a lot of people would have seen this chart before. I just wanted to quickly show it because we've talked about the brain, being impacted. We've talked about the face and how that can be impacted, but we know that the whole body can be impacted during the pregnancy, and that the whole body is developing throughout the whole pregnancy. So depending on when that prenatal alcohol exposure occurs and how much exposure occurs depends on what could be impacted. So it could impact on your heart. It could impact on your limbs. People can present with different malformations that can occur because they've had prenatal alcohol exposure. It can impact on the development of your kidneys, on your lungs, on all these different organs and systems of our body that can be impacted due to the prenatal alcohol exposure. So that's why we do really think about it as a whole body condition. The other thing that we can think about is about all the other impacts that can occur. So we've been focusing on the impacts that are happening for the offspring, in these development, behavior, these features, but there's impacts that can happen across a whole range of levels. So impacts that can happen for the person who's pregnant, can impact on their nutrition, impact on how you absorb nutrients, and that's obviously really critical during the pregnancy. Alcohol use impacts on the placenta, how the placenta develops and how the placenta functions. And then there can be pregnancy impacts from alcohol as well. So it can increase your risk of having miscarriage or having a preterm delivery. So there's a range of different impacts that can happen from prenatal alcohol exposure. This is some research that we've done at UQ. So we've been really interested in all the different physical health problems that can occur from prenatal alcohol exposure. And so this paper just gives you a bit of a whip through some of the different conditions that we looked at and compared rates of people who had FASD compared to what the prevalence is just in our Australian prevalence data. So you can see that on most of the health conditions that we looked at, our people with FASD presented with higher rates of these health conditions. And another area that we've been doing a bit of research on at UQ is around sleep problems, right? So we know that sleep, we all know how critical sleep is, but we know that children with FASD can really struggle and have a lot of sleep problems. So we found that 66% of people reported that their child was having sleep problems, and these were the different type of sleep problems. And we found that these sleep problems are really impacting on the functioning of the caregivers and the functioning of the family, and particularly this early morning waking one. Whilst that was occurring at the lowest rate, it was the most impactful for families. So just something that was really interesting and to be aware of. Okie dokie. So we're running out of time. So what I might do is quickly whip through this little bit, and then I'll leave the suggestions or other suggestions around, because we've discussed a bit about treatment adaptations already, but I have got a whole bunch of just ideas and information in there for you guys to follow up on if you're interested. This is something that's really close to my heart. I'm from a remote country town. This is my town here, Corby, where I was born and from. So this is really important to me. And obviously, as with everything in Australia, getting access to care in rural and remote areas is challenging, right? So I've put down a few considerations. I've sort of touched on some of these already, but things that I would encourage people to think about is that this does not have to be something that happens only in specialist settings. Everyone can get involved in gathering this information. If you're a GP, if you're a nurse, if you're a health, any sort of allied health professional working in any context, you can gather this information and contribute to the assessment process. You may need to link up with some people in some specialist clinics to help you make those diagnostic decisions, but that support is available. Reach out to the clinics. There's on the FASD hub, you can put in there your location and look for services that are available. So reach out to your closest clinic or clinician that's listed on the hub and work with them to help make these assessment and diagnostic decisions together. whilst we require input from different professionals, so we need to have some sort of medical professional, we need to have our allied health guys, this doesn't have to happen in the same context. So it doesn't need to be, you know, what a big barrier is, people will say, oh, well, we don't have a multidisciplinary team, you know, we can't do this. But this doesn't have to happen all at the same time, all in the same place. It might be different people in different clinics collecting different information and then sharing that together and discussing to make these diagnostic decisions. And obviously in rural and remote settings, we've got to be a bit creative because we may not always have access to all the health professionals that we have in our big cities. But that doesn't mean we can't do something. It doesn't mean we can't do what we can to collect what information we can collect and then access support from other people. I think a key thing to consider, because when people look at all those neurodevelopmental domains, commonly they go, oh, well, that's so many areas, you know, we can't do that, it's huge. But the thing to remember is we don't need to assess all those areas to make a diagnosis of FASD. So remember from the criteria that it's 3 areas at a minimum, right? Obviously, the more information we can collect, the better to help understand, you know, that neurodevelopmental profile. But we've also got to be pragmatic. You know, we need to get people access to this. And then once they get a diagnosis, they can get on NDIS, they can get access to further assessments. You know, you can recommend, if an OT is not available, then on NDIS, they could get access to an OT assessment or get access to a speech and language assessment. Just because they don't have it right now doesn't mean that we can't make that diagnosis and get things started. So that'd be my quick practical suggestions. This is a draft diagram that we're working on for the revised guidelines to help people think a bit creatively about this, so that different people could collect different pieces of this information and have one clinician, you know, review this. In a rural and remote setting, you might only have one person. In, you know, in other settings, we may have a whole multidisciplinary team that you can access, but that may not always be available. So I guess what our message is don't let that stop you. Just because you haven't got this flash whiz bang multidisciplinary team of people, don't let that stop you from doing something and getting started on an assessment with someone. Here's an example of some stuff that we did. Check if you're interested. Here's a few papers that we did looking at implementing assessment for FASD with Gidgee Healing up in Mount Isa. So just thought I'd flag this as an example of where we've tried to, you know, think a bit outside the box and get something happening in a more remote setting. And there's lots of other people out there who I know are doing this as well. So it definitely can be done. And I would just encourage people, you know, just to have a crack. Nacho is currently running a campaign about FASD. Just thought I would flag this because our Aboriginal community controlled organisations can play a great role. Commonly, they've got access to different disciplines, you know, all based in the same location that could be contributing to assessment as well. So I think this is a great place to tap into that could be helping us with assessment. And Nacho's running this great campaign at the moment with some beautiful resources. So I encourage people to access that and share those resources. Right, I'm aware that we are down to 5 minutes, so I'll leave you guys to read through the final couple of slides there, where I've just again left a bunch of tips and resources about further things you could think about in the way that we're delivering treatment.
Thank you so much for that, Natasha. We've got quite a few questions that have come through in the chat, so I'll do my best to kind of get through them. One of them says, with the overlap of symptoms between ADHD and people are assuming ASD as well, how important is it to get a FASD diagnosis?
Yes. So there can be, as with all neurodevelopmental conditions, right? We know that with all neurodevelopmental conditions, we see overlap in symptoms. So you'll commonly see people who have ASD, who have ADHD, who have language impairments, who have intellectual disability, you know, all these things overlap, and it's the same with FASD as well, right? But at the end of the day, we're trying to understand that person and what's going on for them, and so that we can get the most effective treatments for them. And something that is really important with FASD, and why it can be really important to get that diagnosis, is we do see really differential treatment effects for people who have FASD compared to other conditions. So this is, as someone in the chat there has said, we find that with these kids, they are really dysregulated. And that is something we see, right? The extreme nature of the behavior and emotion dysregulation for people who have FASD is really quite noticeable, and really can need quite a different approach to some other conditions. And also we can see really differential medication treatment effects. So having that information about prenatal alcohol exposure can be really important for understanding what medication may be helpful. And so that can be really challenging for people with FASD, because say like with your ADHD, your stimulant medications, if someone's got ADHD, they're typically really effective, right? That's not always the case for people with FASD. And actually a lot of the time the stimulant medications may not be effective, and we've got to try other types of medications. So it is really important to understand what is the most accurate diagnosis for that person, to really help us in treating them and supporting them in the most effective ways. Yeah,
and bringing up that dysregulation, often we think that a stimulant-based medication is going to be the best for that, to regulate that and to help people, whereas what you're saying is that may not always be the case.
Exactly. Yeah.
There's a question about saying, at what age would you start to be able to get a clear diagnostic picture, assuming that there is no facial features?
Yes. So that can be really challenging. So obviously, same with anything, right? The earlier we can get the help, the better. So early assessment is always going to be good. I mean, the great thing with NDIS is the early intervention package, right? So you don't have to have a diagnosis to get on that early intervention package. So what we find is that actually the time when you're changing over on the NDIS, when you're turning 7, is actually a good time, because once you're over 6, we can pretty much we've got a lot more assessment tools that we can use on you once you're sort of 6, 7, even sort of once you into that sort of school age. Our assessment batteries can be a lot better, and we can get a lot more understanding about your functioning, and also just you've developed more. And we tend to find too that as kids get older, the challenges increase. There are more requirements are placed on them at school. It's more complicated, and things can really start to unravel. So obviously the earlier the better, and encourage, if you have concerns, get in there and get a developmental assessment early and get on that early intervention package to get access to those supports. But then, around that time frame when you're changing over anyway is a good time, around that 7, to get an assessment.
And I suppose that leads us on to one of the other questions there that says, obviously you're saying there's differences between assessments you would do pre that kind of 6, 7-year-old. Obviously then you've got further assessments when people reach that kind of teenage. And there's a question that's being asked to say, are there difference in assessment or diagnostic criteria in adults compared to children?
No, so there's not different criteria. There's different assessment tools. So different tools are available for different age groups. Depending on your age, we can use different tools. And as you get older, so once you sort of hit that school age, generally the tools are better. Sort of the tools under that age, I would say, are not as sensitive to pick up some of this stuff. And it can be that the level of challenges have not become as apparent yet either. So it just depends on the situation, but the criteria itself doesn't change for your age. So even as adults, it's the same criteria, but there just may be some different assessment tools available. Yeah.
And I am conscious that it's 1 minute past 11, and I know that you had another meeting that was starting at 11. So I'll just use this one last question as the kind of the wrap-up question, which has been asked: do you have any recommendations for parents, carers struggling to get adequate funding support through NDIS for a child with FASD diagnosis and comorbid ADHD and oppositional defiance disorder?
Yeah, look, the biggest thing is getting access to a good assessment. So it's really about, like, obviously with NDIS, it's really about your level of functional impairment. So having that evidence to show your level of functional impairment really strongly, and having, you know, advocating for that, having someone support you if you're a carer, if you're a parent, having someone, if you need it, you know, having someone go to those planning meetings with you. You know, we will go to those planning meetings with people and advocate for them in these sessions, so that, because the reality is that NDIS is trying to spend less money, right? They're trying to not spend as much money, which I understand, because there's situations where money has not been well spent, like, let's be honest, but we don't want people to not get the funding that they need to be able to be successful in their lives. I think it really does come back to having that quality evidence of what those impairments are and advocating really strongly in those planning meetings. So that would be, yeah, that would be my advice.
Thank you. Thank you, Natasha. There's a few thanks have come through already, but I suppose what we'll do now is we will wrap this up due to the fact that we are going over time. Thank yous are starting to flood through. So on behalf of Insight, APSAD, the webinar series, Natasha, thank you very much. I know you're very busy. You have a clinical workload as well. Very grateful for your time for this very important webinar. We've had an absolute load of people who've attended, who I'm sure will benefit and will use your presentation slides in the future.